And our next speaker would be, hello? Yes. Welcome, ma'am. Good afternoon. Hello, ma'am. Are you able to hear me?
Is now don't miss out on the biggest of fashion shopping favorites from the biggest brands.
Yes, Dr. Rajlakshmi, ma'am. Are you able to hear me, ma'am? Welcome, ma'am. Yes.
Am I clear? Am I audible?
Yes, ma'am. Yes, ma'am. You're audible, ma'am. So, on behalf of 23rd IPS PG Convention, I welcome you all and welcoming our chairpersons for the session, Dr. Ajay sir and Dr. Roma Goswami. Dr. Ajay sir is currently working as a professor and head in the Department of Prosthodontics at Bharati Vidyapeeth Dental College and Hospital, Pune. Sir has done his graduation as well as his post-graduation from Bharati Vidyapeeth Dental College and Hospital, Pune. He has many research publications and numerous national and international publications to his credit. Welcome, sir.
Thank you so much.
And Dr. Roma Goswami, ma'am, is a professor and head in the Department of Prosthodontics at Bharati Dental College and Hospital, Meerut. Ma'am completed her graduation and post-graduation from King George Medical College, Lucknow. Ma'am has 35 national and international, numerous international and 4 books to her credit. She is on the editorial board of Journal of IDA Meerut Kent branch. We welcome you, ma'am. And so I hand over the proceedings to the chairperson, sir. So kindly take over, sir.
Yeah, thank you so much. I think I'll be introducing Dr. Rajlakshmi. What do I say? It's a proud privilege for me to introduce my dear friend, my colleague, Dr. Rajlakshmi Banerjee, or Raji as we very fondly know her as. Okay, and she's probably one of the most soft-spoken, gentle-hearted, and a genuine person I've ever come across in my life. So it's genuinely a privilege for me to introduce you, Rajlakshmi. Dr. Rajlakshmi is presently working as the Associate Professor or Reader and PG Guide at Department of Prosthodontics, BSPN, DCRC Nagpur. She is the co-in charge of the Maxillofacial Unit, Prayas at BSPN, DCRC Nagpur. She's editor, Journal of Prosthetic Rehabilitation, IPS Nagpur branch, scientific co-chairman of the 40th IPS National Conference Nagpur. She has been awarded the first prize for best faculty paper presentation at various scientific events. She's a dedicated academician, clinician, researcher with a passion for teaching. I'm sure about that. And there are many publications in various national and international journals to her credit. And she has been invited as a speaker at various national and international conferences. So, welcome, Rajlakshmi.
Thank you, Ajay.
And we're waiting for your presentation.
So, can I share my presentation?
Yes, ma'am, you can.
Is it visible?
Yes, ma'am.
So, a very good afternoon to the respected chairpersons, organizing committee members, IPS head office, senior faculty, postgraduate students, and my dear friends. I am extremely grateful to the organizing committee of the 23rd IPS PG Convention, the organizing chairman, Dr. Narendra Padiyar, organizing secretary, Dr. Gaurav Pal Singh, and my very dear friend, Dr. Pragati Kaurani, the scientific chairman of the PG Convention, for giving me this esteemed platform, this honor and privilege to present at this Indian Prosthodontic Society PG Convention. Coming to the topic of today's presentation, understanding deprogrammers, what and how. We will all agree that the last 1.5 years, we have been trying to reboot and restore harmony in various spheres of our life, work, family, friends, relations. And when Dr. Pragati told me about this topic, I thought it is the same ethos. It goes with the same sentiment of deprogramming and restoring and rebooting the masticatory apparatus back to its normalcy, harmony. The roadmap for this presentation would be, we'll see what is centric relation. We'll be answering some questions like what are muscle engrams, pathophysiology of muscle dysfunction. We'll see what is deprogramming, when to deprogram, why to deprogram, locating the centric relation position, bimanual palpation and the load test. We'll see what an anterior deprogrammer does, types of different deprogrammers, duration for the use of deprogrammers, and when should deprogrammers not be used. We'll differentiate between deprogrammers and splints, some reviews and conclusion. So as we said, we try to reboot and deprogram the masticatory apparatus back into harmony. So what is that situation? That situation or that relation is the centric relation position. We will all agree that organization of occlusion at the centric relation position is very important for a harmonious relation between the teeth, the muscles, and the temporomandibular joint. Centric relation, as it is defined, it can be the maxillomandibular relationship, which is independent of tooth contact, in which the condyles articulate with the thinnest avascular portion of the articulating disc when the condyles are placed in the anterior-superior position against the slopes of the articular eminence. When the mandible is restricted to only the rotatory movements, and this is a position from where the physiologic maxillomandibular movements can be done, in which the patient does a vertical lateral movements, and it is a clinically useful, repeatable reference position. Now, in this position, the mandible can rotate or the condyles can rotate along the terminal hinge axis. This is restricted to an interincisal opening of about 20 to 21 millimeters. Anything beyond that, the condyle translates in the glenoid fossa, and then it does not remain in the centric relation position. Also, as we saw, centric relation position is that when the condyle articulates with the thinnest avascular portion of the articulating disc, which is more capable of taking up stress and dissipating the stress. If the condyles articulate with the anterior or the posterior lamina, there will be discomfort and pain. So it is necessary that the condyles articulate with this thinnest, non-innervated avascular portion of the articulating disc for it to have a stress-free or a dysfunction-free or a disease-free joint. We will all agree that centric relation position is that position where the condyles are in the best musculoskeletally stable position. Mounting the cars on the articulator after taking bites using the centric relation can give us or can help us to eliminate and detect interferences for occlusal equilibration procedures. All this was when it is all ideal. But does it remain ideal all the time? It is the same with us. We strive to remain and restore the ideal, the best versions of ourselves, but we all of us have some bad streaks, the habits, long time use of mobiles, televisions, nicotine, caffeine, lots of them. And we strive to ward them off, to be and to restore the best of us. Similarly, muscles also have that habit, or which is called as a muscle engram, which is registered in the muscle memory. It is shown to be a conditionable reflex which lasts for about 2 minutes, which is far less as was previously thought. So these muscle engrams are built up over repeated actions of opening, closing, excursions into various positions. The muscles remember this and it is registered in the muscle memory as a muscle engram. So till the muscle engrams are proper and the elevator muscles, the depressor muscles, the masticatory mechanism works in tandem with each other, in coordination with each other, it is all okay, it is all fine. But as you can see in the second picture, what happens when there is an interference, when there is a faulty restoration, when there is a malocclusion, when there is supraeruption? So anything that will deviate the mandible or not allow the mandible to close into the centric relation position. And what is the muscle doing? The muscle is trying to, by virtue of its muscle engram, trying to position the mandible, the condyle, back into the centric relation position. So what happens here is hyperactivity of the musculature, pain, and dysfunction. So this, as Dawson calls it, occlusomuscular disorder, is the commonest type of orofacial pain or temporomandibular joint disorder. As we saw, this muscle engram, which is not able to position the mandible properly into the centric relation position, the muscles become hyperactive, and this incoordinated contraction prevents proper functioning of the muscles, which are used to coordinated pattern of opening and closing with the antagonist muscles. So what does the muscle do? It tries to avoid and escape the interfering contacts and changes the pattern of opening and closing. That means it develops a new muscle engram, which is a devious muscle engram, not the ideal one. So what do you mean by deprogramming? Deprogramming is nothing but breaking of this devious muscle engram by using an anterior deprogramming device, which is nothing but a small bite plane in the anterior teeth, which will allow the mandible to close into centric relation position by releasing the contracted or the hyperactive musculature. By releasing them, relaxing them, the mandible is guided to close back into the musculoskeletal stable position. And this is deprogramming. As we said, it is a small bite plane introduced in the anterior teeth so that the posterior contact, the interfering contact, is eliminated and the mandible can be closed. The condyles can easily guide the mandible, the condyles to be placed in the most stable centric relation position. So answering some questions, when should we deprogram? Deprogramming can be done when, after evaluation of the load testing, when there is no tenderness of the joint, no pain, when there are other symptoms of instability seen like occlusal facets, abrasions, adhesions, or positive findings of muscle tenderness of the pterygoids, masseters, or temporalis, in all such conditions, it is necessary to deprogram. The primary objective of deprogramming is to break the muscle engram, to record an accurate centric relation, and to differentiate between intracapsular temporomandibular joint disorders and the muscular disorders. So in all these conditions, to achieve all this, it becomes necessary to deprogram. So centric relation position can be located using these two commonly used techniques like the chin point guidance technique and the bilateral manipulation technique. The disadvantage of the chin point guidance technique is that it often pushes or it distalizes the mandible more posterior than the centric relation position. And therefore, according to Dawson, the bilateral manipulation technique is a more accepted method for locating the centric relation position. So how to do the load test? Load test is done using the bimanual manipulation method. We start by loading the joint under light pressure. The pressure is proceeded to a medium and then to a firm pressure, and the patient is asked for tension or tenderness during the load testing. So if the muscles properly relax and there's no pain, the condyles, as we can see in the picture, can be properly placed in the centric relation position without any pain, as the condyle is approximating against the thinnest vascular portion of the disc. There is no pain. So this is a negative sign for a load test. There's no pain. Whereas when the condyles cannot articulate properly and there is pain in the muscles, that means it is an intracapsular temporomandibular joint disorder. So this is the load test. So I have made a video to demonstrate bimanual palpation and load testing. So we'll just see that. So that was about the demonstration of bimanual palpation and load testing. Now coming to what are the errors that happen during bimanual palpation. So as Dawson says, the most common error during bimanual palpation is mostly due to trying to force the mandible into centric relation too early. So the deprogramming has not happened. The lateral pterygoids have not relaxed. The elevator muscles are not relaxed, and you are trying to push or distalize the mandible into centric relation. So that is one error which will give you a false positive result. The patient will experience pain. And second error is because of less firm pressure applied for seating the mandible into centric relation. That means the amount of pressure that should be applied to seat the condyles into the glenoid fossa is less, and it will give you a false negative result. Both of these should be avoided. Some other errors that have been mentioned in literature is like incorrect doctor and patient position. So as I showed in the video, what should be the proper position of the patient during load testing and bimanual palpation so as to ease the mandible into centric relation position. It can fall into the centric relation position easily. Incorrect doctor position, if the seating is not upright, if the shoulders are not relaxed, the dentist tends to stress or push the mandible into a more distal or a more posterior position than the centric relation position. Again, placing the fingers over the entire mandible. As I showed, all the four fingers, the index fingers, have to be placed near the angle of the mandible with the little finger just distal to the angle and fingers close together. So this position of the fingers is very, very important for proper bimanual palpation and the load testing. If the fingers are placed all over the mandible, the force vector that is formed forces or distalizes the mandible into a more posterior position than the centric relation position. Another error that happens most commonly with inexperienced dentists or postgraduates is jiggling the mandible. If you're not confident about the technique, you slowly jiggle the mandible or you try to rush the patient into centric relation. That will not allow the elevator muscles to relax and you will not attain a proper load testing, or the centric relation may not be recorded properly. Just remember that the patient should be guided and never forced into centric relation. So how does the anterior deprogrammer help? It acts as an anterior fulcrum. It disengages the posterior contacts, the posterior teeth, which in turn helps in releasing the hyperactive contracted muscles, which helps the elevator muscles to use or to elevate or to provide the directional forces to the condyles, to the angle region, and it helps in seating the condyles in the musculoskeletally stable superior anterior position of the mandible. So downward force is applied by the chin, by the thumbs, and upward force is applied at the angle. This allows for a turning the doorknob type of action, which seats the mandible into the centric relation position. Also, the occlusal stops or the incisal stops, the bite plane that is present by a deprogrammer on the anterior teeth, will help the elevator muscles to seat the condyles into the superior anterior position more effectively. So what are the different types of deprogrammers that are used? I've just selected all the deprogrammers that are commonly used in practice. So cotton rolls, leaf gauges, Lucia jigs, NTITSS, the nociceptive trigeminal inhibition tension suppression system deprogrammers, Cranham deprogrammer, Dawson Academy's B-splints, the Coy's deprogrammer, and the mini deprogrammers. So we'll see each of it. So cotton rolls, very commonly used in practice. A cotton roll is kept in the anterior region. The patient is asked to bite on a cotton roll for 15 to 20 minutes. And just as the cotton roll is removed, as we saw in the video, a bite is recorded. But normally in some patients where the muscles have been into a devious closing pattern, the muscle engram may not be broken in such a short amount of time. So extending the use or maybe using the cotton roll just for the load testing can be fine. And then a deprogrammer can be made, fabricated, and given to the patient for overnight use or for a longer period of use. And then centric relation should be recorded. That should be a better scientific approach towards using a cotton roll. Leaf gauges, again, very commonly used deprogrammers. So these come as 10 leaves riveted together in a bunch. They are of 0.01 inch thickness, 0.5 inch wide, and 2 inches long. These leaves can be placed in the patient's mouth. A bunch of leaves can be placed, seeing that there is posterior disocclusion. And then one by one, the leaves can be removed to check for the initial point of contact. And then you can start with the occlusal equilibration, marking the first point of contact, going on reducing it till harmonious occlusion is achieved. So leaf gauges can act as deprogrammers, as also it can help in achieving occlusal equilibration. Lucia Jig, another very popularly used deprogrammer. This can be made with a cold cure acrylic resin or pattern resin chair side. It is adapted to the maxillary teeth and has a bite plane, a flat bite plane for occluding with the lower incisors. This can be used for a longer time. 24 hours of use is the most recommended period for Lucia Jig, and it can also be used for bite registration of centricrelation. So I'll be demonstrating again a video of fabrication of Lucia Jig and how you adjust the Lucia Jig in the patient's mouth to record the centricrelation.
Ma'am, in your recorded video, there is no sound displaying. In your
Yes,
recorded video, there is no sound displaying.
there's
You have
no
to show
sound.
the sound also.
I can hear it here actually.
Ma'am, you have to share it again. When you share it, you have to share sound also.
Okay, what I'll do is I'll go on speaking with it.
Okay.
Okay. So you can see that we have mixed the autopolymerizing resin, and as it enters the initial dough stage, we have taken it out and started mixing it in the hand. You can just skip it slightly so that you can see the actual adaptation. So it is adapted on the incisal region. The excess is cut off. So what we had marked was 2 to 3 millimeters apical to the gingival margin of the central incisors and palatally 2 to 3 millimeters to the gingival margin of the central incisors. The excess is removed. It is to be given a triangular shape so that posterior or the lingual side is narrower as compared to the labial side. A bite plane is fabricated. It is made plain. The excess has to be cut off. And then you start closing and checking for indentations. If the mandibular teeth are producing indentations, and then you'll reduce that to produce a flat plane. So now after the jig is ready, it is finished and polished, and you'll place it in the patient's mouth to check for the opening that it achieves. So you can see that the jig is tried in the patient's mouth. All rough edges have been smoothened. The frenum is checked for relief. Check the platform. All excess from the distal of the centrals is cut off. You ask the patient to close. Check that only the anteriors or the incisors are touching. No posterior teeth is touching. So you check that no other contact is present, only the anterior is touching. So only then it will help in deprogramming. So now how to adjust this jig is you take an articulating paper, place in between, and you ask the patient to produce, you ask the patient to protrude, go back into the most posterior position, do the lateral excursion so that you get a needle point or the Gothic arch tracing intraorally on the bite platform. So that is being done. The patient is being asked to do all the movements. What you want to achieve is a 3 millimeter round circle, that is a centric relation point, and then make a bite which will coincide with that point. So we are trying to ask the patient to do all the movements and get a needle point tracing. So what we get initially might not be an exact needle point. All the points that are coming into contact will be marked. We have to keep just the 3 millimeter center circle, and rest of the markings have to be removed. So we'll go on reducing the bite plane till we have a 3 millimeter circle. So you can see that the 3 millimeter circle has to be maintained and rest of the portion has to be trimmed off. So this is how you trim off the other contacts other than the centric relation point, and you check it back in the patient's mouth. So after all the extra points of contact are removed, it is placed back in the patient's mouth and again checked. So again the patient is instructed to make mandibular movements, protrusive movement, as back as possible, right lateral, left lateral. Okay, so now this is the tracing that we have received. So here we can see that the 3 millimeter inscribed circle can be seen clearly, and there's one wing on one side. So that is one contact that is still remaining. So keeping that 3 millimeter point, the wing on the other side has to be reduced. So we'll check again in the patient's mouth. We have reduced it and finally it is checked again. So again, patient is asked to do all the protrusive and laterotrusive movements. And now we'll check for the centric point. So now we can see that we have achieved the 3 millimeter circle that coincides with the centric relation point. And when we need to make a bite registration, we'll be keeping this back in the patient's mouth, asking the patient to close in the same position and use a bite registration paste to make the centric record. So you'll keep it back, ask the patient to close. You know where the point of centric relation is. Okay? And you'll make a centric record bite using the bite registration paste. So that is about how to adjust the Lucia jig and use it to record the centric relation. Now, another type of deprogrammer is the nociceptive trigeminal inhibition tension suppression system. Now, this device is nothing but a deprogrammer, but this was popularized in earlier times as a headache relieving appliance. So in patients with temporal and occlusal muscle headaches and facial pain, this comes as a ready-made plastic pattern from which the internal surface can be relined using thermoplastic materials, and then it can be given to the patients, and as it deprograms and relaxes the muscles, it helps in deprogramming and also relieves headaches and temporal pain. Another type of deprogrammer, the Cranham deprogrammer, is usually given for a night. It is the same with a bite plane, lingual or palatal to the maxillary anteriors. Only changes here, you have a palatal extension which covers the palate and engages the teeth, maxillary teeth. As it is given for the night, it has to be retentive, and therefore it can be used for a night and helps in deprogramming. So this is also used commonly for the occlusal equilibration procedures. Coming to a very popular in recent times deprogrammer, that is a Coy's deprogrammer. In addition to the Cranham deprogrammer, here there is a labial bow which touches all the surfaces of the maxillary teeth, and it is said to be used for a longer period of time. In patients where deprogramming is difficult, the muscle engrams are difficult to break. In such patients, Coy's deprogrammer can be given for, usually it is mentioned 2 to 4 weeks. But again, 2 to 4 weeks is slightly a longer time, and you should be carefully monitoring that no supraeruption of the posterior teeth happen during this time. The Dawson Academy's B-splint is another deprogrammer. It is also called a splint because, as you can see, that it covers all the teeth. It can be used for patients with clenching or bruxism, can also be used as a night guard to protect the teeth. It also has a bite block in the front, just distal or just lingual, palatal to the maxillary anteriors to help in deprogramming. So this not only deprograms but also protects the dentition of the patient from clenching and bruxism. So as it covers all the teeth, it can be used for a longer period of time, and it also helps bruxers from the habit. A mini deprogrammer is again a modification of the Dawson's B-splint, wherein the posterior contacts have been removed. It is also used as a night guard to release the muscles, to relax the muscles, and to treat bruxism. Now, other than breaking the muscle engram, as we saw with different deprogrammers, there are secondary objectives like for the Dawson's Academy's B-splint, it can be used for prevention and treatment of bruxism. It can prevent teeth from occlusal trauma. Like the Cranham's deprogrammer, it can be used to relieve tension-type headaches and migraine. So these are the other uses of an anterior deprogrammer. As much it is important to know when and how to use a deprogrammer, it is equally or more important to know when to not use a deprogrammer. So a deprogrammer should not be used when the load test suggests the presence of intracapsular pathology. If chronic anterior disc displacement is suspected, seating the condyles using a deprogrammer can progress a reducing click into a non-reducing click and can worsen the situation. In patients with intermittent lateral pole click or patients who have recently developed lateral pole clicks, it has to be used with utmost caution and with careful monitoring. Also, in patients with medial pole displacement, there can be significant pain if a deprogrammer is used, as the pressure will cause the condyles to be placed on the retrodiscal tissues. So in such cases, it is very important to note that deprogramming should not be attempted. Now, regarding the time required for deprogramming, there is various durations suggested for the use of deprogrammers for various appliances also. Like 15 to 30 minutes is what is given for the Lucia Jig or for the leaf cages and for cotton rolls. Lucia jigs can be used for a longer period of time also. Again, it depends on how the muscles are responding. If the muscles are easy to deprogram, then a smaller time or a shorter time duration can be used for deprogramming. But in more patients where the engram has been built for over a longer period of time, it might be difficult to break that engram. And for such patients, longer time, like 1 hour, or more scientifically accepted is the 24-hour duration wear of the prosthesis of the deprogrammer. So the patient is given the deprogrammer, asked to wear for the whole day. And the next day, the first thing that the patient does is come to the dental clinic. As soon as the deprogrammer is removed, the bite has to be recorded. So that is the more scientifically accepted duration, and that is required for deprogramming the muscles. Now, deprogrammers like Coy's deprogrammer is said to be used for 2 to 4 weeks, as they say, but again, with careful monitoring that there is no supraeruption of the posterior teeth happening during such times. So how to differentiate?
Dr. Rajlakshmi,
Yes.
5 minutes are left, so kindly just speed up your presentation.
Yeah, okay. So deprogramming versus splinting, as we all have already seen, deprogramming is basically to break the muscle engram. It covers only the anterior teeth, should be worn for very less amount of time, and there is a risk of supraeruption. Whereas splinting, though these terms have been more commonly or interchangeably used, but splints, the primary objective is to position the mandible in a required position, be it a stabilization splint or an anterior repositioning splint. It can be used for a longer period of time, and there is no risk of supraeruption as it covers all the teeth with single point contacts. So some review as by some studies by Dr. Ramachandran et al. Have shown with CBCT imaging of the condylar positions and assessment of clinical symptoms that using splint therapy after deprogramming has given favorable results. James Mackey showed that after deprogramming and with bimanual palpation, the muscles were able to position the condyles in the centric relation position, so deprogrammers can be used favorably. Kinderneck, in his study after 12 hours of deprogramming, showed that the position of the transverse horizontal axis in relation to the condyles, there was a difference of just 0.5 millimeters. So maybe more amount of deprogramming would be required in such a case. Coming to the recent advances like transcutaneous electrical nerve stimulation, which is also called as the neuromuscular bite registration technique, wherein the patient is given transcutaneous electrical nerve stimulation for about 30 minutes and then bite is recorded. But with this technique, the disadvantage is that the muscles become super relaxed, and normally the bite registration gives a more amount of vertical relation as compared to the other techniques. A recently available, over-the-counter available splint or a deprogrammer is the equalizer, which is also called as the self-adjusting deprogrammer or splint. And this is nothing but a fluid-filled or a liquid-filled pads which are placed over the occlusal teeth and the labral surfaces of the anterior teeth. Based on Pascal's law, as any pressure applied on a fluid is transmitted all over, so the muscles can relax and it leads to deprogramming of the muscles as that is suggested. So summarizing, I can say that the anterior deprogramming device allows for an accurate recording of the centric relation position. It can help the condyles to be placed in the most musculoskeletal stable position by breaking of the muscle engrams and the devious posterior contacts. It can also be used as a valuable tool in diagnosing and management of temporomandibular joint disorders to differentiate if it is a intracapsular pathology or a muscular dysfunction. These are my references. So I would urge every one of the postgraduate students and the faculties, we have seen difficult times, but not to give up. We have to keep running even if the obstacles are high, and be prepared like the small mouse there to accept and to face the challenges. So I have prepared a video for our dear postgraduates to keep on jumping. Even if they fail, they fall, but never fail to rise again and try again. You have to go on jumping high till the goal is achieved. These are definitely difficult times, and we as postgraduate teachers are there to give a pat on the back and say that it's okay, go on, we are there for you. So just take that leap of faith, jump up high, go for your dreams. We are there to hold you if you fall and rejoice in your success. So postgraduate students, just go on. So as I come to the end of my deliberation, I would like to thank many people, God Almighty, the first, my parents who are listening to this back from Kerala, the chairpersons, my departmental staff, my husband, my family, my daughter, and Dr. Usha Radke ma'am, my HOD, who's been believing in me ever, forever, and Dr. Sai Deshmukh, who has supported me, Dr. Neelam Pandey ma'am, and the whole department for believing in me. I'm extremely grateful for the chairpersons, Dr. Ajay, my friend and senior. So you being there, it was even more special for me. This being my first keynote, so I'm taking the liberty of thanking so many people. I thank the organizing committee for giving me this chance of presenting a keynote address, and a big thank you for this. I hope it's visible. As is said, when you aspire something truly and deeply, the whole universe conspires to give it to you. So this has been that moment for me. Thank you so much. Thank you, chairpersons. Thank you, Dr. Roma Goswami ma'am, for chairing my session. Thank you, Dr. Ajay.
Thank you, ma'am, for this wonderful presentation. There are two questions from the delegates, ma'am, if you would like to take.
Yes, sir. Yes, sir.
Yeah, the first question is that in Lucia Jig, what should be the posterior gap and how we can determine the gap as to how do we know that how much has to be the posterior separation when we are making the jig?
What is given in literature is 2 to 3 millimeter in the bicuspid region and taking care that there is no contact in the posterior. But as we go on adjusting the Lucia Jig to record the centric relation or the first point of contact, we go on reducing the Lucia Jig. Then we get the first point of contact, and that is recorded with the centric relation bite. That is transferred to the articulator, and that helps in occlusal equilibration as that high point is reduced and you get the occlusal the occlusal equilibration is done.
I hope that helps the students. The second question is, ma'am, any mode of deprogramming in edentulous subjects?
Deprogramming is basically done to relieve or to eliminate the posterior contacts and to break the muscle engram. So otherwise also in the edentulous patient, we are going to record the centric relation. The muscles are already relaxed and lax. So I don't think there is any need for deprogramming in the edentulous patient because there are no contacts. Whatever is remaining is the muscles, and which have to be taken into the centric relation position.
Probably they wanted to know, like we have these patients who go into pseudo class 3 kind of a situation. So probably they wanted to ask, is there any method to break that muscle memory and to get the patient into centric, ma'am? Anything you can tell about that, ma'am? Probably the delegate wanted to know about it.
But habitual positioning is without any teeth contact. This is just the mandible because there is nothing present to hold it in the centric relation position that the mandible is advanced. So by using the proper bimanual technique and asking the patient, like we make the centric record, when we do a centric relation bite record with the needle point tracing where the mandible is slowly trained to go back to its centric relation position, I think that achieves that.
Thank you, ma'am.
Thank you so much.
And thank you, chairpersons, for the time that you have given, ma'am. And on behalf of the organizing committee, I would like to extend my appreciation through these certificates, ma'am. Thank you, Ajay sir.
Thank you so much. Thank you for the
Thank you.
opportunity.
Yes. Thank you, Roma ma'am.
Vijay, can I take a minute?
Yes, yes.
Yeah,
Though I
Raji.
thank, yes, sir. I was actually waiting for you, and because I saw you right now, I just wanted to say thank you.
Good
And
afternoon, sir.
Good
sir, I've
afternoon,
already
Vijay.
given my acceptance. But
So,
I'm really thankful
thank you.
for making
Thank you.
this
Thank you,
moment
Raji.
even
Thank you,
more
Raji.
special, even more special for me. A golden moment, a dream
it's an
come
honor.
true moment where my senior, my friend Ajay is present.
Great.
Rupesh sir is present, and I'm giving my first keynote. So thank you so much.
Thank you, Raji. Thank you, Vijay. Ajay, thank you so much.
Thank you so
It's an
much.
absolute pleasure.
Good to see you, sir.